Hi everybody, and welcome to part one of two presentations on the pelvis and hip. So we start with a quick review of the anatomy, looking at X-ray case images, and then we'll have a look at what you're supposed to see on each of the radiographic projections, and then we'll look at a series of fracture cases. So here we have a quick review of the anatomy on the AP pelvis image. So you may wish to pause the video, if not just let it run and we'll move on. So here we have the horizontal beam lateral hip, and here is the anatomy that you should see on that projection. Again, pause the video if you wish, otherwise let's just keep rolling. And here's what we should see on the turned lateral hip. So again, pause the video if you wish, otherwise we shall move forward and I'll hand over to Hannah.
The adult pelvis is made up of a pair of innominate bones and the sacrum. Now, the innominate bones are made up of the fusion of the ilium, the ischium and the pubis, and that usually occurs between 7 to 8 years of age. Whereas the triradiate cartilage is replaced to form the acetabulum between 20 to 25 years of age. So our pelvis is made up of 3 bony rings. So our main pelvic ring is made up of the pair of ilium and the pubis, and then it's joined by the symphysis pubis. And this is a fibrocartilaginous joint. And our symphysis pubis should measure around about 5 millimeters. When you look to assess for alignment, you look at the superior border of the pubis and it should be in alignment. You might get a small step of 1 to 2 millimeters, which is acceptable, but anything more than 2 millimeters, and you need to be considered disruption to the symphysis pubis. So the SIJs, or sacroiliac joints, they're a fibrous joint posteriorly and they're a synovial joint anteriorly. And what you're looking for with your SIJs is that they should have symmetry. They should be looking at around about 2 to 4 millimeters. Our sacrum is consisted of 5 fused embryonic segments. And our lateral masses fuse to form the sacral ala. So when you're looking to assess the sacrum, you want to look at your sacral foramina, and these slightly concentric sclerotic semicircles for the sacral foramina, and you're looking for breaks in the cortex through here, which might indicate an underlying sacral fracture. Your coccyx, which we can't really visualise on this image, that consists of 4 rudimentary vertebrae. Because of the huge variation in the normal appearance of it, we don't x-ray for coccyx anymore. And besides, it's not going to change patient management. So when we're assessing the pelvis, we need to make sure that we look around both the inner contour and the outer contour. You want to be looking at the obturator foramina for any breaks in the rings. You want to be assessing the SIJs, the symphysis pubis, the sacral foramina, as I've mentioned, and importantly you want to be looking at the acetabulum. So you need to look behind the femoral head at the acetabulum to assess for fractures. And if you have a paediatric pelvis, you need to check hypophyses as well. Now the pelvis, because it's made up of 3 rings, with the knowledge of when you break a ring, it's important that you need to search for a second break, because more often than not, if you break a ring, you get 2 fractures. And this is particularly important in the pelvis. We sometimes call it the bagel theory. So if you tear a bagel, you can break it in one area, and then on the opposing side, you'll either break it or you'll tear the ligaments. So it's important that when you look at a pelvis x-ray that you search for that further fracture if you already find one. So when we assess the pelvis for injuries, we can draw some lines that should follow a nice smooth contour along the surface of bone. And this is to assess that there's no displacement. So if you've got displacement to the lines, that'll indicate you've got an underlying injury. So our ilioischial line, which is number 5, this follows the broad cortical surface of the sciatic notch, and it comes down, unsurprisingly, along the ischium, along the medial border of the ischium. So if you get a disruption to the ilioischial line, what that means is that you get a disruption to the posterior column. Now our iliopectinal line, this follows the border of the ilium and runs all the way down along the pubis. So if you get any disruption to the iliopectinal line, this indicates that you've got an anterior column injury. So if we look at Shenton's, which hasn't been drawn in, when you draw in Shenton's line along the inferior cortex of the superior pubic rami, and it should form a nice smooth curvature along the medial border of the femoral neck. So Shenton's line is very helpful for assessing for fractures to the superior pubic rami and to fractures of the femoral neck. So as I've discussed before, we've got our sacral arcuate lines, and these first few segments should be a nice smooth cortical rim bone. So if you get any crumplings along there, that'll indicate a fracture. It's important to assess the acetabulum, so you need to look through the femoral head, you need to be able to visualise the acetabular roof, and you need to try and identify, if you can, it can be quite tricky sometimes, the anterior acetabular wall and the posterior acetabular wall. And you need to try and search that area for fractures. I wouldn't worry too much about the radiographic view, the teardrop. That tends to be quite helpful when it comes to assessing for joint effusions, which is beyond the remit of PAN 3006. So for you, the main focus is to look at the ilioischial line to assess the posterior column, the iliopectinal line to assess for the anterior column, Shenton's line to assess for fractures to the superior pubic rami and the femoral neck, and then of course your acetabulum. When we specifically want to assess the hip, we do hip views, which is essentially the proximal third of the femur. If it's for trauma, you must always perform a horizontal beam lateral x-ray. And the reason because of this is because it allows for really good visualization of the femoral neck. And that's because the femoral neck is really vulnerable to fracture. So you want to make sure that it's completely it's fully visualized so you can carefully assess for any fractures. If, however, you are assessing the proximal femur for, say, osteoarthritis, you can do a turned lateral hip, because the area of interest that we're particularly looking at is the femoroacetabular relationship, which is quite a nice example here where we have degenerative changes. We've got a little osteophyte going on. And we can see from this turned lateral hip why we shouldn't perform it for trauma patient, because the greater trochanter is completely superimposed at the femoral neck, and so therefore you cannot exclude a femoral neck fracture. Now that's really important for you to remember, because there are going to be times when you will have a GP patient who comes walking into the department and the GP will have asked the question, does this patient have a femoral neck fracture? And even if that patient is mobilising, you're still going to have to do an HPL hip, because only the HPL hip allows for adequate visualisation of the femoral neck. So pelvic trauma is normally caused by high energy trauma or by blunt force trauma. And perhaps 60% of those cases are made up of motor vehicle accidents. The remaining 30% are due to falls, and crush injuries are responsible for about 10%. So high energy traumas are associated with really significant soft tissue injuries. And the other type of trauma is with low energy trauma, and these are essentially our elderly patients that have a fall from standing, so they're essentially a fragility fracture. Now the gold standard for pelvic trauma is CT. However, the AP pelvis is often included as part of the primary survey. And what's happening now is that pelvic binders are the current stabilisation method of choice. And so with a pelvic binder, what this means is that it stabilises pelvic ring fractures and exsanguination pelvic trauma. The important thing about a pelvic binder is that it needs to be placed around the greater trochanters, not around the iliac crest. That's really important. And providing the pelvic binder is in place, you don't actually need to perform a pelvis as part of the primary imaging survey in the resus. You can actually wait until they're brought round for the secondary imaging survey in the department, because that pelvic binder is actually holding in place. Now, we sometimes do Jude views. So Jude views are taken to assess the acetabulum, and whilst in the context of high energy trauma you won't be doing Jude views, where Jude views become really helpful are for elderly patients who sustain stable acetabular fractures, or for patients who have had a high energy trauma and they now go back to fracture clinic for follow-up views. So this is why we still teach Jude views. So the important thing to understand with a Jude view is that your right posterior oblique, what this means is that the right hip is closer or posterior to the detector, and therefore your left hip is more anterior, so it's elevated. So right posterior oblique, this means that the right hip is posterior towards the tube and the left hip is elevated. And the great thing about this is that it allows for really good visualisation of the anterior rim of the right acetabulum. And this means that it's very good at also assessing the posterior column. Whereas on the left, what we're looking at here is we're looking at the posterior rim of the acetabulum and the anterior column. So I'm going to talk a little bit more about anterior and posterior column injuries and a little bit further on, but I'm just letting you know about what you're looking for with the Jude view. So when you do Jude views, you always make sure that you collimate to the entire pelvis, and then you always do both your right posterior oblique and then you do your left posterior oblique. So therefore, with your left posterior oblique, your right hip is elevated and your left hip is posterior to the tube. So essentially, your left hip is closest to the detector. And what this means is that you get a really good look at the anterior acetabular rim on the left and the posterior column. And then it's really good looking at the posterior acetabulum on the right and the anterior column. Now, other views that we do are inlet and outlet views. So again, in major high energy trauma, you're having a CT scan, so you don't need to do inlet and outlet views in that context, but like the Judo views, patients who have sustained significant pelvic injuries, when they come back to fracture clinic, they may need to have inlet and outlet views. And also, you may do inlet and outlet views again in exactly the same way with elderly patients who sustained essentially stable injuries, and so it just gives a really good visualization of what's going on there. So our inlet view, as you can see, what happens is you angle the beam, you angle the central ray 40 degrees caudate, and we can see very clearly that it's very good at assessing for inward displacement or rotation of the pelvic brim or the acetabulum. So it's really very, very good indeed. And it's particularly good at looking for posterior displacement of the ilium at the SIJs, whether you've got any diastasis of the sacroiliac joints, and whether you've got any inwardly displaced fractures of the anterior arch. So it is really quite a good view for visualization of these things. So our outlet view, which you're looking at between 35 to 40 degrees cephalad, as you can see, is really very good at looking at the whole of the sacrum. It really opens it up. So you're looking for any vertical displacement of the sacrum. It looks really good at visualizing the whole of the sacral foramina. It's excellent visualization of the pubic rami and the ischial rami. And look at the obturator foramina. So you can quite clearly see how the two views are very complementary. So injuries to the pelvis can be divided into significant trauma, where you get major displacement of the fracture fragments, resulting in disruption to both the anterior and posterior column. Or they can be divided into acetabular fractures, and then you get these minor and more isolated fractures. So to evaluate whether an injury is stable or unstable, the mechanism of injury can actually be quite helpful in identifying a fracture pattern. And you also need to appreciate which pelvic ligaments have been disrupted. So the pelvic bones are held together by really strong ligaments, and these are crucial for maintaining pelvic stability. So the sacroiliac ligaments, these are the strongest in the body, and if they're disrupted, what you can get is separation of the pelvic bones. And this separation of the pelvic bones can lead to extraperitoneal bleeding. Breaks to the pelvic ring or fractures at the margins are essentially considered to be stable fractures. So the key to assess whether something is unstable is that if you get two or more fractures that affect both the anterior and posterior columns, that's a very unstable fracture. So it's important to assess for instability, and there are key radiographic signs that will indicate this. So if we remember that our sacroiliac joints measure 2 to 4 millimeters normally, if you see sacroiliac displacement of more than 5 millimeters in any plane, that's an indicator of instability. If you see a posterior fracture gap, so a gap not impaction, then that indicates that you've got instability. Remember, an impacted fracture where the bones are crushed together is inherently stable, and it only becomes unstable when that fracture is then unpacked. So if you get an avulsion of the transverse process of the fifth lumbar vertebra, that will indicate that you've got disruption to the iliolumbar ligament. If you have a fracture to the lateral border of the sacrum, this indicates that you've got disruption to the sacrotuberous ligament. And finally, if you have an avulsion of the ischial spine, that means that you've got disruption to the sacrospinous ligament. There are three patterns of force that create three typical radiological features, which are the AP compression, the lateral compression, and the vertical shear. And these are basically based on the pattern of mechanical force. So our anterior compression fracture, this is when you kind of get struck by head-on by, say, a car. And what happens is that the force hits you anteriorly and it causes the symphysis pubis to open up like a book, hence being called an open book injury. So you typically see these with horse riders and motorcyclists. Now, in a type 1 anterior compression injury, the symphysis pubis is only opened up by less than 2.5 centimetres. So remember, a normal symphysis pubis is 5 millimetres, and if it is more than 5 millimetres but less than 2.5, basically it's essentially quite stable because the sacroiliac ligaments have been maintained, and so therefore stability has been maintained. Occasionally with these injuries you can get fractures to all four rami without any disruption to the posterior arch. So if you get this injury, it's referred to as a straddle fracture. What you'll see is that fracture fragments are displaced superiorly, and it's believed to be a direct blow to the perineum. So you can get it with horse riders if they are, for example, jumping and then they land very forcefully back onto the pommel of the saddle. Generally speaking though, bilateral rami fractures are normally caused by lateral compression fractures. So here we have our classic open book injury. So we have marked diastasis of the symphysis pubis. And remember, once it's more than 2.5 centimetres, you're then going to get involvement of the sacroiliac joint. Now, if we look at our left SIJ, we can see that we've got normal width of 2 to 4 millimetres. In comparison, on the right, you can now see that there's diastasis involving both the anterior and superior. So remember, the superior aspect is the fibrocartilaginous joint, which is posterior. So we have complete disruption to that SIJ. And you can see, if you look on the left side, if you run your line along the ilium and then over to the sacrum, you can see that the alignment has been preserved. In comparison, if you go along your iliopectinal line and you run along the cortex of the ilium and to the sacrum, you now have this step. So that's another way of looking for this injury. So this is a really significant injury, and you can get massive hemorrhage with this, which is definitely a problem, which can be really problematic, and it can result in extravasation. And so that's why we now use pelvic binders to prevent that hemorrhage. So what is it? It's an open book injury where the symphysis pubis and right SIJ. How? Moderate diastasis of the symphysis pubis and mild diastasis of the right SIJ. So our lateral compression injury makes up 50% of all pelvic fractures. And so what happens is that you tend to get this force from the lateral aspect of the pelvis. So it's usually if you've been T-boned in a motor vehicle collision, or if you've got a pedestrian who's been struck from the side. And you may see it if a person falls from a height and they land on their side. So the key with this injury is that the hemipelvis is crushed inward, and because the bones are crushed inward, it means that the stability is maintained. So morbidity is usually because of other reasons, such as trauma to the head and to the thorax. So what happens is you then get fractures to the pubic rami, and these fractures to the pubic rami can be oblique or segmental, and quite often they're comminuted. So when we look at this patient, we can see that the force has come from the right side, and the right ilium has been crushed inwards. And we can now see the fractures through the pubic rami, and there's a horizontal or transverse fracture through the superior pubic rami, and then we've got overlapping fracture of the inferior pubic rami, and we've got comminution to the pubic rami on the left. Now, occasionally with these injuries, you can get a central fracture dislocation of the femoral head where it's been driven into the acetabulum, which actually hasn't occurred in this particular instance, but it's things that you need to be aware of. We can see we've got the artifact from the pelvic bone wall, which is holding this patient's pelvis in place. So what is it? It's a fracture where it's bilateral pubic rami. On this image, you can't actually appreciate any sacral fractures because of the distortion to the pelvis. And how will be lateral compression. So our vertical shear injuries are usually from a fall from a height. Occasionally you see them in motor vehicle collisions where you have the occupant with their legs fully extended. So what happens is you get a unilateral fracture pattern. So it's normally the ipsilateral anterior and posterior pelvic columns. Okay, and so what happens is that you get cephalic displacement of the hemipelvis on the side of the impact. Importantly, you will get an avulsion of the transverse process of the L5 vertebra, so indicating that you've got disruption to the iliolumbar ligaments. So it's a really unstable injury because it affects both columns, and it's normally associated with really severe vascular and soft tissue injury. So if we look at this vertical shear injury, the difference between this and an open book injury is that you have in this case, the left hemipelvis has been driven superiorly. So we can see that the superior inferior pubic rami and ischial rami have been displaced superiorly. We can see the marked disruption to the left SIJ, but importantly, if you look carefully, you can see that there's been complete fracture of the left transverse process of L5. So therefore this will help you to identify that it's a vertical shear injury. So So what is it? You've got fracture and diastasis. So you have where the symphysis pubis, your left sacroiliac joint, and the left transverse process of L5, and how vertical shear. A Malgaigne fracture is a very specific type of vertical shear injury. So in comparison to the previous vertical shear injury, there is preservation of the symphysis pubis. And what you have with this particular vertical shear injury is that you have, so remember it's the ipsilateral pelvis is involved, and rather than separation of symphysis pubis, you get bilateral fractures through the superior and inferior pubic rami. And we can quite clearly see that. And we can see that there is an element of superior displacement. If you then look at your SIJs, if you look at your left SIJ, then there's a normal joint space, which we can note particularly inferiorly is quite hard to appreciate. But if you then look at the right SIJ, we can see we've got diastasis. And if you look carefully, there's a lytic line extending across the iliac crest, so you have a further fracture through this location. So what is it? It's a Malgaigne fracture where right sacroiliac joint, an iliac crest, and then you have double pubic rami fractures on the right. How? Vertical shear. So acetabular fractures can be basically divided into whether they're a result of high energy trauma, so you tend to see these in young patients, such as road traffic collision, or if they occur in the elderly, and these are basically to do with a lot less force. However, acetabular injuries can have quite complex fracture patterns. They may include the femoral neck or even the head. So it's really important to understand the acetabular columns. So you have your anterior column, so essentially it comes down the anterior wing, the iliac wing, down into the anterior portion of the acetabulum, and it incorporates the superior pubic rami. So that is your anterior column. So your posterior column starts at the sciatic notch, runs down into the posterior acetabulum, and then it incorporates the ischium. The Judet and Le Tournelle classification system describes 5 basic types of acetabular fracture patterns. So you don't need to know these for the exam, but it's just to give you some context to appreciate the different types of fractures. So type 1 is where you just have the superior rim involved, and that's of the anterior column. Type 2 is of the posterior rim, which is of the posterior column. So now we have a simple anterior fracture, and these tend to be seen more commonly in the elderly, and these tend to be a fragility fracture, so essentially fall from standing. Then we have our posterior column fracture, and these aren't particularly common at all. And then finally you've got your central or transverse fracture, which involves both the anterior and posterior column. And then these are more likely due to a central dislocation of the femoral head. So here we have a central or transverse acetabular fracture. We know that because the femoral head has protruded centrally. So it has caused displacement. And we can see the fracture line running out through here. And we can see marked breaks in the cortex. So remember, when you're assessing the pelvis, you need to be running along the, in this case, the iliopectoral line, and we can see following the iliopectoral line the disruption to it. We also then need to follow along our ilioischial line, and again we can see that has also been disrupted. So we know that this is both an anterior and a posterior column fracture by following those two lines. So what is it? It's a fracture where it's the left acetabulum and left superior pubic ramus, how central protrusion and comminuted. So here we have a really great example of how important it is to make sure that you go around the cortex of each and every bone and to follow those lines that will help you, because it's only when you come along the iliopectoral line that you'll see the step in the cortex and be able to identify that you have an acetabular fracture. The ilioischial line has been preserved, so essentially this is an anterior column fracture. So what is it? It's a fracture where it's the right acetabulum, how minimally displaced. So here we have a left posterior oblique, so that means that your right hip is going to be anterior and your left hip is going to be posterior, so therefore it's closest to the detector. And with this image we can quite clearly see we've got really good visualization of the posterior rim of the acetabulum, and we can quite clearly see this undisplaced fracture through here. We've also got excellent visualization of the anterior column. So here's a really good example of why judo views can be very helpful when you're looking for fairly simple fractures to the acetabuli. So what is it? It's a fracture where it's the right posterior acetabular rim, how it's undisplaced. We've come to the end of part 1 of the pelvis, and I look forward to catching up with you again for part 2.